Who would like to start today? Brent, are you there? See, you're on the list.
Yes, can you hear me?
I can. Would you like to go first?
Oh, sure.
All right. I'll give you control.
Can you see my screen?
Yes, I can.
Okay. I just have a few cases here this week. This case is interesting in a number of different ways. This is a relatively young patient with repaired congenital heart disease. Had an AV canal, and you can see part of that repair through here, through the interatrial septum, interventricular septum there. This case is first interesting in the sense that you have, let me blow this up just a bit, we have a mechanical mitral valve prosthesis here. And you can see from this Sene that one of the leaflets here, the anterior leaflet, is fixed, it's stuck. And one of the things that, of course, we can use CT to look for. And in this case, echo suspected that there was a thrombus adjacent to this fixed leaflet, but wasn't able to characterize it very well. But you can see here this clear round filling defect around the base of this leaflet that is causing it to be stuck in this position. So this patient has mitral valve stenosis here due to the fixed leaflet and thrombus along the base of the leaflet. The other interesting thing here is that you can see here as we're scrolling down, the coronary sinus is actually opacifying to the same degree as the left atrium is here, and you can see that it's actually, there's contrast that's refluxing from the left atrium into the coronary sinus. So there's an unroofed coronary sinus that wasn't really appreciated until this CT was done. And the third interesting thing about this CT is that you notice that there's a lot of tracheal and bronchial calcification. And the question arose when I was reading this out, why does this very young patient, this patient is in the her early 30s, why so much tracheal calcification that you typically see is with age? But of course, this patient was anticoagulated with Coumadin for the mechanical valve, and that's also in the differential for tracheal and bronchial calcification. So presumably this is due to longstanding anticoagulation use in this patient. So I just thought this case was interesting for a number of different reasons.
Brent, why is the azygous vein so plump? Is there some SVC obstruction or something like that that's causing the azygous vein to dilate up?
Sorry, the other interesting thing about this is that there's actually azygous continuation, so of an interrupted IVC. So we reach a little bit of the upper abdomen here, but you can sort of see that there's an interrupted IVC there.
And Brent, what's their branching pattern of their airways? It looked, at least on some of those images, fairly symmetric.
Let's see, I think that...
Good point.
Yeah, I mean, I think we may have bilateral hip arterial bronchi here, so...
That goes with continuation.
So a very interesting case. Here's another one. I don't know if this one has been shown recently. This
hey,
right?
Really quick, Brent, was that thrombus or was it pannus on the valve leaflet?
That was it's not proven yet, but that presumably was thrombus. So one reason to suspect that as well is that she has a history of being poorly anticoagulated, so her follow-up has had periods in which the valve stopped functioning. In fact, she was at an outside institution, and the valve was fixed like that. And then right before, the day before surgery, properly anticoagulated, or several days before, apparently the valve started working again, and presumably she's been developing thrombus along that off and on as her anticoagulation status goes back and forth. So
it'd be interesting to see a follow-up once she is properly anticoagulated, but it sounds like that is more likely.
Yeah, that's what I'm thinking under those circumstances. So this was another case. I don't know if this has been shown recently. I haven't seen it on this meeting recently, but this interesting device has a lead pulse generator with a lead going to the right neck, and then another lead going to the right hemithorax here by the diaphragm. And this is a hypoglossal nerve stimulator. Have people been seeing a lot of these recently, or?
Oh, what does it do?
So this is interesting. Let me pull up the PDF here. So I was hoping that people had not seen this recently. So this is a hypoglossal nerve stimulator, and it has a lead that goes to the neck that actually stimulates the hypoglossal nerve. And when it's stimulating it, it gives it some tonic activity that helps retract the tongue muscles and helps maintain airway patency during sleep. So the idea is the patient turns this on only right before sleep, and it then senses, these are sensing leads that go to the chest near the diaphragm, and it senses the breathing pattern of the patient, and it sends stimulation to the hypoglossal nerve during sleep. So that theoretically will help pull the tongue back and maintain airway patency. And apparently there's a few studies showing that this actually does improve measures of daytime sleepiness and fatigue and things like that. So it's actually working for some subset of patients. So this is it's just interesting if it comes up. This is the lead going to the hypoglossal nerve, and this was the sensing lead that's along close to the diaphragm, projecting over the lower lung.
So it's close to the diaphragm, but it doesn't need to be at the diaphragm?
No, presumably not.
Okay.
So the images I've seen, the schematics don't show it actually touching or projecting over the diaphragm, just kind of projecting over the lower lung. So just an interesting device. Okay, and then just one or two more. So this is something I hadn't really seen before. I'd be curious people's thoughts on this. This is a 66-year-old woman who came in, and she had a chest CT that I saw before I started looking through her history. And so just scrolling through this, you see clusters of small nodules. Some of these have a branching pattern, tree and bud pattern. As you scroll down, it's worse within the lower lungs. You can see findings in the middle lobe and lingula here. So in some volume loss. So this looks like could be certainly compatible with chronic MAI, and you could wonder if she's aspirating a little too. But one of the things I would think about is chronic MAI. I started looking through her folder, and it turns out she's had several sinus CTs, and this is on presentation or sinus CT, and you can see that she'd actually had some nasal symptoms, and she has this nasal mass on the left, and it's filling the sinus here, partially filling it. And this was thought on the sinus CT to be concerning for malignancy. So this was biopsied, and they got granulomatous inflammation out of this, and then they cultured it, and it grew MAI. So presumably this is MAI in the lungs and MAI in the nose that then responded to treatment. And not showing you the follow-up, but this had decreased, and the lung findings had decreased. So wonder if anyone else has seen, MAI involve the sinuses or nose.
Wow.
So I just thought that was a very interesting case. I've never seen that before.
Nope. Okay, thanks, Brett.
And I guess that's it.
All right. I'm going to show a few. I was gone last week, and then if there's time, I'll show some more. But I'm going to show a trio of cases here. So this is one case here. This was a 77-year-old having a CT scan for cough. And the only interesting finding was right here. You know, we see calcified nodules, nodes all the time, but we notice this little protrusion into the airway, and I'll throw it up on a coronal. So this is a little broncholith here. Now, whether or not that's the cause of his cough, I'm not sure, but you can see there's the primary lesion, and it drains up the appropriate lymphatic pathway. For David, here are all the splenic calcifications, so that's how we know this is histo. But this is a little broncholith here, probably not the cause of his cough, but that's one finding. So this big chunky node is just kind of pushed on it there. The next case is another one I ran into in the same week. This is, unfortunately, I don't have thin cuts. It's an outside study. Another patient here who had, you can see there's the calcified lymph node in the lower left paratracheal zone, the subcarinal zone, and then we see it both sides, and calcifications in the lung. But out here, there's a nice triangular area of consolidation, and you can follow it back to this calcification here. I do have some coronals, they're whole body coronals, but I'll blow them up, that really nicely show this area here, and you can see there's the calcification right by the airway. So here's another broncholith, or the other possibility is it's just a calcified granulomatous lesion that's extrinsically compressing it, but I get the sense it's going into, at least partially into the airway here. I don't have the axial thins to be certain. But another case here, and this patient had bilateral histo, which sometimes happens. You see the calcifications on both sides. And then this last case was sent to me from the group in Augusta, which is this is a really nice. This was a pre-op radiograph. I think it was for a GYN surgery, and you can see there's this opacity here, and I should have a lateral somewhere. Let's see, buried in here. But there's a CT scan, if I can get it to come over. So these are just scanned JPEGs. I apologize for them doing that. Let me get the CT image for you guys. There we go. And you can see here, there's the calcification. You've got the atelectatic lung, some calcifications around it, and then mag this down a little bit. But this is from the bronch, and you can see it protruding into the lumen here. It's kind of got that yellow color there like that. So they can debride these. Obviously, they can't remove them because they're coming from out the airway. And then sometimes patients will fragment these and cough up little chunks of calcium. It's called lithoptosis. So 3 different examples of broncholiths. They're kind of all the same, varying locations and degrees of severity, but mostly from histo in the U.S., but TB elsewhere in the world. If there's more time, I'll show some other cases as well. So who'd like to go next?
I can show a few.
All right.
All right, you should see my screen.
Good.
This is the one I wanted to show last week. Then I got interrupted. But it's better that Jeff's back anyway. This is courtesy of Brett Elliker, who saw this at the VA last week, and he was pretty sure he knew what was going on and showed it to us anyway because it's an interesting case and it was also a little bit of a conundrum. And we've shown a lot of different things on PE studies. I've never seen this before, and it's a pretty interesting case. So here you see right upper lobe. You've got low attenuation, what looks like a filling defect. It certainly could be a little embolus. And then when you look at it on lung windows, though, you see that there is an airway right here, and then this thing abruptly terminates into an air-filled structure. And you shouldn't have bronchi paralleling each other like this. So it sure as heck looks like an artery that has air in it. And what's also interesting is look at the rest of the anterior segment of the right upper lobe. You have decreased perfusion peripherally within this segment, and this whole dilated air-filled thing goes all the way out, and then you can see filling of contrast, I think, further out in the periphery of the anterior right upper lobe. That's not the only one, too. If you go more inferiorly, I think this is the second area where you have the same thing. It's kind of almost looks like side-by-side bronchi, which shouldn't happen. Yeah, so there's one, and then there's the second one right here. So the question was, have you ever seen air fill in pulmonary arteries like that? Because that's what it looks like. No, I had never seen it. I was working with Rick Webb. He had never seen it. And certainly the patient has a little bit of air in their pulmonary artery and in their right ventricle as well. So we thought these were macroscopic air emboli to pulmonary arteries. He didn't have PEs elsewhere. So the patient was not really that symptomatic. I don't know why. I mean, obviously, they had some suspicion of pulmonary emboli. So when we don't know, or when they don't know what to do, they frequently just get a follow-up. And you can see the very next day that the findings have completely resolved. You have normal opacification, restoration of flow, and similar attenuation of the lung in both of these areas. So I've never seen that before. I don't know if anybody else has, but it's pretty cool case. And it's just interesting how you have this contrast, this air contrast fluid level, essentially like an airlock beyond that, where you can't get contrast out there or blood flow. So at least that's what I think is going on. Has anybody seen that? I mean, obviously we see air in the main PA all the time and in the right ventricle, but I've never seen this.
No,
that's pretty dramatic. Leif showed me one just today in which the patient that we imaged here had more air than your patient in the right heart and the pulmonary artery, and we found one tiny dot of air round in one vessel, but never seen a case like yours before, or never appreciated it.
Yeah. No, I just thought it was cool. Rick wanted to call this the double barrel bronchus sign when you see these parallel, but like this. I like it as an illustration, obviously, that the pulmonary arteries and the airways should parallel each other, but you shouldn't have two airways side by side like that. So it all fits with the understanding of basic anatomy. So. All right.
Yep, that case.
Yeah, and Jeff, so the lock field just protects, so you can't delete something. Jeff had just sent me a text. So once I have these, I just have them locked so I don't accidentally delete them. I may remove them from a folder, but so I don't eliminate them from my database altogether.
Yep.
This was a bizarre one. This is a patient who had a radiograph, and this was around the time of another CT, and you can see there's this abnormal convexity along the right heart border, and it's situated here, anterior mediastinal, along the right heart border. It was obscuring that interface. This CT was done last summer around that time, and you see it's fatty, and there's little streaks of soft tissue. So it was thrown out, maybe a thymolipoma, maybe a mature teratoma, or even something. He's man who's 58 years old. He came back in, and I don't know if he had any symptoms at this time, but you can see there's a little change in appearance of this thing, and it's now got a little bit more stranding in it, maybe a little bit more soft tissue. The overall size isn't any different, and he's also got this big blastic thing. He's got prostate cancer, I think, is why he has blastic expansile bone lesions. But they took this out. I didn't see it until the post-operative radiograph. But all they got was nodular fat necrosis. So it was, and they were saying epicardial mediastinal fat necrosis. Obviously, it's not like the phenomenon that we see with a lot of our cases where you have just the fat that kind of appears, and with that little targetoid lesion and the surrounding inflammation. But this looks like it was something that was already there, either that or it had necrosed in the past and became this circumscribed and discrete lesion. But it was kind of interesting that they didn't see any sort of underlying lipoma, any sort of tumor, and you can see they just had a fatty nodule that had undergone necrosis. So I don't know.
I think the problem they have, Travis, is they don't recognize that this is not a normal fat collection that might have some necrosis in it. So, you know, they really don't have the gross understanding that you have as an imager.
Yeah.
So this was probably a lipoma. I don't think it was herniated fat in this location, so it's probably a lipoma that might have had some necrosis in it.
Yeah, that makes more sense. I mean, they had the whole thing, so you would think they would be able to differentiate, but I don't know.
I think the lipoma looks like normal fat, so
Yeah.
they don't recognize that it's fat where it wasn't supposed to be.
Yeah, I like that as a better explanation. I think this was saved in our prelim file as like a possible thymolipoma or something which is a seemingly elusive diagnosis that I still yet to see in real life. So yeah, I like the idea of it being a lipoma that necrosed, but I don't know. I think your point is well taken, though, that pathology isn't always correct either, 100%. So.
It is curious.
Curious. All right, and then one more. This is just one that I came across for other reasons. This guy, you can see, he's had long-standing steroid use and other medications. He has HIV, and he has this kind of buffalo hump morphology, which I've shown a case of before, and I think Jeff has as well. It's a really subtle radiograph, and he came in with severe chest pain, and he's got just some reduced lung volumes, a little bit of retrocardiac stuff, and you can see on the CT that was done subsequently, about 5 hours later, that he now has fairly extensive pneumomediastinum. And we've shown a lot of cases of pneumomediastinum and Macklin phenomenon, or Macklin effect, being spontaneous pneumomediastinum. But in this case, I show it just to differentiate. They had given him oral contrast, and you can see that he has this collection of contrast outside of his esophagus distally, more along the left anterolateral portion of his esophagus. And there's no frank communication, but you know that this is torn. And he's one of the minority of patients with Boerhaave syndrome who actually didn't have any sort of episode of vomiting. And he developed chest pain, severe chest pain. And I'm not exactly sure what his other symptoms were, but there was no emesis, which is kind of interesting. And it can happen in a minority of patients. One of the reasons I show it too is just to differentiate. If you don't see this collection of contrast outside, the presence of the effusions and the surrounding inflammation is still much more worrisome than our typical spontaneous pneumomediastinum. And I bring up, this is a paper, because this comes up all the time, especially with patients that come into the ED with spontaneous pneumomediastinum from like asthma, coughing fit, something, and they always want to do further exams to evaluate for esophageal leak. This was one done at WashU a few years ago, and they looked at spontaneous pneumomediastinum and then compared with that from esophageal pathology. They found that if you see pleural effusions, if you see subdiaphragmatic air, these are findings that are much more suggestive of a secondary process like esophageal rupture. So yeah, there's not a lot of data on this. I wish we had some ACR appropriateness criteria for further evaluation of spontaneous pneumomediastinum, just because I think that a lot of the times these tests are futile when you do swallowing exams and even CT if they don't have other findings like effusions, like history of vomiting or areas of consolidation from the complication. So, but just a nice example of a Boerhaave syndrome. So I don't know if you guys find the same frustration, but there always seems to be this need to make sure, even if there's no risk factors for esophageal perforation, that they do a swallow exam or CT esophagram or something.
Yeah, Travis, I think we end up getting CTs, which don't usually help, but I found that if we find interstitial emphysema in the lungs, that's very reassuring, at least to our surgeons, that we don't really need to pursue this, especially when there's no history that fits with an esophageal issue or a tracheal issue.
Right, and here they and this was for tracheal and bronchial injury that they found that obviously you could have pulmonary interstitial emphysema. They didn't even they said one case of esophageal pathology had PIE. Mm-hmm. Yeah, I agree with you. I think that this is, but yeah, the other point is just if you see effusions, consolidation, whether some of this is atelectasis, some of it's aspiration or whatever, I mean, that should certainly alert you a little bit more. But if you don't see those, then you can be pretty confident that it's just spontaneous. So, all right, I'll stop there. I've got more as well, but
all right, David, Howard.
Jeff, I've got a quickie.
All right. We see your
So-
rentgenogram.
You said, or maybe a radiograph. I'm not sure whether it's a röntgenogram. But this person has this fine branching abnormality in the lungs, and I think I have a lateral view for you. You can see it's got a nice branching pattern, so it's sort of dendriform. It's very bright, and it seems to be located anteriorly here and at the bases. Let's see, he has some interesting findings elsewhere. He's got this abdominal radiograph showing this object, and here is an elbow view here showing some of this bright material near the elbow. So putting it all together, the stuff that's in his lungs actually came from this device here, which is a broken thermometer.
That's awesome.
And this is mercury injection. This is a way to get high, you know. And this case is from the late 70s. I'd seen cases like this in San Francisco, but this case here was from Seattle. It's in an old teaching file that I've now digitized. So I don't know why he swallowed the thermometer, maybe to hide it or something like that. But when the mercury hits the lungs and causes this, you know, probably causes some obstruction of small vessels, it causes release of cytokines, and for some reason that makes people high, or maybe there's this sudden pulmonary hypertension that feels really good. So people can do this more than once. So mercury injection and mercury embolization. So you showed air in vessels, and I'm showing something at the other end of the density spectrum here.
Yeah, that's the extreme other end.
Yeah.
Can you show the lateral? Is there any? Can you see any of it pooling in the RV? I have one case from when I was at Mallinckrodt that it was a weightlifter that had injected for some unknown reason, but you could see some of it pool in along the RV dependent portions.
No, I don't think I see that here, and I think he must have been. I wonder if he was lying, if he was prone almost, because this stuff seems to be so anterior. You know, maybe he was hunched over, got issues with situs, and has this coarse branching abnormality in the bases here, which corresponds to abnormal bronchi. And let's see, Jeff, can you turn off the recording for a second here, and I'll go back and disguise the name. You've seen the radiograph here, and indeed this person has Cartaginer syndrome and has bronchiectasis and a lot of bronchiolitis, so there are small airway shadows throughout here. And situs inversus, so the liver, which is kind of fatty, is on that side, but look at the spleen over here. It really has polysplenia. And then there's this big structure back here, which we can follow north, and this is his azygous vein. So he has azygous continuation of an interrupted abdominal inferior vena cava. So I wasn't aware of this before. I thought that the Cartaginers people had situs inversus totalis, but 12% of them actually have heterotaxy. So they can have things like polysplenia and azygous continuation because their organs are not uniformly switched into a mirror image. There can be these anomalies, and some organs are switched and some aren't. So I was not aware that it wasn't always a situs inversus totalis, but it could be actually heterotaxy with some organs switched, others not. This is the first time I've seen that. I don't know whether you guys have seen it.
What does it look like, David?
What?
Does he have? What kind of airways does he have?
I'm glad you asked that because it looked the same to me as Brent's case. They look pretty symmetric.
Let's see. I'm looking for a right upper lobe bronchus on the left, and you're absolutely right. So let's check it out on coronal here. I love this conference, guys. I learned so much. So it looks as if he has a long bronchus on the right, and
maybe that is a right upper lobe.
Pretty symmetrical with the left, actually. So is the pulmonary artery going over its bronchus? I'm not sure the pulmonary artery is going over that side. The pulmonary artery is clearly going over on the other side. That's going over very nicely.
I think it is inversus of his airways in his lungs.
Yeah, I don't.
It's right upper lobe bronchus there.
I don't think we have the left isomerism here. Do you, with a bronchial anatomy?
Doesn't look like it.
Okay, too bad. I could Photoshop it in if you guys would like. So, have you guys seen heterotaxy with Cartaginer?
No, this is the first time.
Nope. Nope. I don't think so.
Okay, those are the two cases I have.
All right, thanks, David. All right, Howard.
Jeff, can you put my screen up really quick?
Yeah.
I pulled up my Mercury case just to supplement David's. This is just from my old emboli talk. This is the one from Mallinckrodt in the early 2000s. And you can see in this case that a lot of it's pooling in the RV, but it looks very similar elsewhere. And he, as far as I know, he didn't have a thermometer fragment in his belly either. So, but yeah, it otherwise looks very similar.
All right.
Oh,
Thanks.
that's it.
All right.
Alrighty, here is an interesting patient. This patient came in with from the outside with a concern for an acute coronary syndrome, had a coronary arteriography which did not show any coronary abnormality. So the thing that was done next was the acute aortic syndrome protocol, and of course we typically get the non-contrast first. So take a look at this, and we see findings really very typical for acute intramural hematoma. And you'll see there is involvement of the ascending aorta, and there you see it there. And also the descending aorta, you can see displacement of intimal calcifications in the descending aorta. But clearly, particularly there is involvement of the ascending aorta. So far, findings pretty typical of IMH, but pretty extensive. But let me bring alongside now the contrast portion, and let me bring up the thin cuts for you. So what's really interesting about this one is that this is going to be a nice demonstration of a case of IMH where one can see intimal tear. So right here is a really nice example of contrast medium passing from the aortic lumen through the tear right there into the aortic wall. And you can see it there, and there's contrast getting into the hematoma or into that portion of the wall there. And the other place, I think there might be a second one right there. I think right there seems to be something like it as well. Not as clear cut, but I do wonder if this is another place in which contrast medium is getting into the wall, and this being the hematoma. So this phenomenon of IMH with features of dissection, or at least an intimal tear, at least an entry tear, is pretty well described, and I think one can find more articles about that. So the notion of an intimal defect in patients with an IMH, and here's another article, an update about IMH, also again emphasizing that one can, at surgery sometimes with imaging like this, show those intimal tears. So perhaps the whole idea of IMH being rupture of the vasa vasorum probably might not actually be true. It just might be an increasing recognition that we can see the intimal tears. But in any event, this is a really nice example of a case in which we can see that intimal tear, at least one, maybe another one right there as well. I think this is the nicest example I've seen of that. Leif has shown the other cases where it's like this, pretty subtle and very focal and easily overlooked where there is an intimal tear when the IMH itself is pretty obvious and quite large. Have you folks seen a case like this where it's quite obvious like that?
No.
No.
You agree? It looks pretty nice, pretty convincing for that phenomenon.
Yes,
Yeah, that's
agreed.
good example.
Yeah. All right, good. Here's a patient. This is an interesting pathology. This is a young person, came here for surgery, having been diagnosed obviously with a large mass on the outside. That's the frontal projection of the chest. Here's the lateral projection, so a solitary pulmonary mass by virtue of its size. We won't be surprised that it's FDG positive, very much so. Here is CT that shows it. So circumscribed, and it is heterogeneously attenuating. It contains quite a large flecks of calcium, dystrophic calcium within it. As you can see there, that is taken out, and there's a differential, but in a young person, one should certainly think of this entity. So this is a case of IMT. Seth showed one previously a couple of weeks ago, but this is a slightly older patient. Nowadays, they might do a panel of different kinds of receptors and CD this and that, basically immunohistochemistry. And apparently one thing that does point towards this is, no, actually look, one of the things they look for is ALK. And those that are ALK negative, it is said, may have a more adverse prognosis. So that's one of the things that they look for. But you can see the kind of things that they stain for. So this is pretty consistent with an IMT in that patient. Here is another person with a very large mass in this patient. So the chest radiograph looks like that. There is some pleural fluid associated with it. You can see there's a lot of calcium there. There's some shift of the heart over to the other side. CT will show, as you might expect, a very large mass, substantial amount of internal, some necrosis, the calcifications, a lot of vascularity and parasitism from adjacent vessels, so a very vascular, very nasty looking tumor in the chest. And certainly the differential diagnosis is sarcoma and other bad things. So this one histologically is a malignant solitary fibrous tumor. And this one does have one marker that's thought to be predictive of this particular entity, which is the STAT6. There you can read the pathologist's description of that. But that's one thing they're starting to look for. So pretty nasty lesion in this patient, but a malignant solitary fibrous tumor. And sometimes these are entirely within the lung. Of course, when it's so large, one can't be sure. But sometimes these are like that too. So a very nasty looking tumor.
Wow.
Yeah. Okay, Jeff, I'll stop there. I'll save some of my others for another time because I think we have some other folks that will show some.
Yeah. Anybody else not shown cases yet? I've got a few more too I can show.
Okay.
All right. Let me show a couple, and then I'll show one or two. Let's see. I've been wanting to show this one for a while, for a long while. This is a patient who'd had a mediasternotomy for an ascending aortic repair. And you'll see here, this is the scan from May of this year, and there's clearly a pseudoaneurysm here. And if I put it on the bone windows, if I can figure out where they are, there you can see it's actually eroded through the cortex here of the sternum. And all this, and there's the graft right there, but clearly this is a pseudoaneurysm here. And this actually got infected. It ended up growing staph. This is an outside CT we found from about a year earlier. And of course, in retrospect, you can see right here were the very beginnings of this problem right there, just below the kind of the graft material where you see that irregularity. There's a little outpouching right there and another one right here. So this was sort of the natural history of this over the course of 1 year of that. So
Jeff, do you think this is a mycotic pseudoaneurysm, or do you think that it was a pseudoaneurysm first and then infected second?
The latter. I think it was a pseudoaneurysm that got infected because I can't imagine it would sit there for a whole year kind of smoldering without some symptoms. And at this point, is able to eat through the bone. So I think you got blood here, you've got bone involvement, and foreign body right here. So it got infected at some point. So they had to go debride this and clean it out. And this was just a fun case. We've seen a lot of these, but nice case here of a right aortic arch, and got a pacer, had heart disease, and on the lateral, you can see as well there's a posterior impression on the trachea. And this patient has sarcoid, which I'm less interested in. I'm not going to go talk about that. You can see he's got the lymphadenopathy. But what's cool is if you look at this arch, it actually is a double arch with an atretic segment. You'll notice the narrowing of the airway here. And this is something I've noticed, and I think it seems to apply every time. When you have a right aortic arch, the brachiocephalic usually comes off the sort of the cephalad surface of the arch. And when you have the double arch with the atretic segment, it seems to come off the lateral margin like you would expect a left arch would, a double arch. So this is a ring here. He was asymptomatic from this, so it's loose enough that this is an incidental finding. Although you wonder with the sarcoid lymphadenopathy confounding it that there is some tracheal narrowing here. So I just wanted to show that case, and then the classic sarcoid here. So double arch with atretic segment. Alrighty, I'll stop there, and if anybody else wants to show some more cases, Travis or Howard.
Go ahead, Travis, if you have any.
Okay, I'll show a couple more. Let me find, let's see, this one. This is a quick case. It's kind of interesting. And this person, they had a chest radiograph in 2015. And this is one of those ones that I can file under the better to be lucky than good category. So this is the nodule that was detected. Certainly might even be a bone island given this perfectly superimposed over the right first rib. So, but they recommended CT based on this. And what's interesting is that maybe you see that there looks like there's a little asymmetry partially overlying the clavicle as well. And so this happens to be a patient that has a solid nodule that we saw in the radiograph, and immediately inferior to that. Now this is you can see is about 9 months later, this CT, and you see this other lesion that looked much more vague on the chest radiograph is now more of a solid lesion. So they took this out, and these turned out to be essentially a collision tumor with hamartoma here, which was confirmed. This is really thick slices. I don't know if you can see any macroscopic fat on the, no, not even on this. But the one below it turned out to be an adenocarcinoma. So side-by-side lesions. And our pathologist was saying that there can be an association with adenocarcinoma and hamartomas coinciding. I don't know. I haven't had a chance to look that up. I don't know if you guys know any of that. You know, they look like they're separate entities here, and she does have some underlying emphysema as well. So this may just be serendipity that they showed up right next to each other. But I don't know if anybody can comment on that.
No, I've not heard that.
So I'll do a little bit more reading into that, but I thought that was kind of...
You know, I think I might have heard that hamartomas can degenerate into carcinomas.
Yeah.
That carcinoma can arise in a hamartoma. I think I've heard that lore.
And just to show you...
The pathologist was implying...
Yeah, and in this case, you can see there's the hamartoma, no uptake, and then this invasive adenocarcinoma is pretty hot at that point. So, but a nice radiograph too, showing the subtlety there. All right, and then this one, just to show you the opposite. Here you can see, this is an old radiograph, nothing going on, and then the patient came in 2014 and obviously has severe emphysema and has this irregular spiculated nodule in the right upper lobe. And this was on a lung cancer screen, so we had nothing else prior to 2006, just showing that it had arisen at some point in the last 8 years. This is one of the things that this is a good that still, I think that a lot of times, even when it looks that ugly, you have to slow down a little, just because they had a PET and you can see it was hot, and this was about 2 weeks later or 3 weeks later. And so they scheduled a biopsy for a couple months later, and by the time of the biopsy, you can see that it's almost completely resolved. And of course, no treatment in between. So this just happened to be a focus of infection that was a really, looked like it was going to be a lung cancer. And I think the speculation, just a combination of the underlying emphysema and the inflammation as well. So
Yeah.
I don't know what everybody else's approach is, but for this very reason, I tend to urge caution in a lot of these, because they want to, do a PET, do a biopsy within a week of seeing something like this for the first time. So this was a 4B, is how it was read, and they just went to PET immediately. So I don't know. I tend to be more conservative, I think, just because of this very reason, and I think a month or two is not going to affect things too much. I don't know. Do you guys agree, or would you be more aggressive with this?
I agree with you, Travis. We find that PET is not a good choice because it doesn't distinguish between a malignancy or an infection. We have a lot of histo around here too. Also, it tends to drive more aggressive behavior, because you have a positive PET with a nodule and you feel more obliged to go after it. And one of the options is a very short-term follow-up, which I think is appropriate for the most part. I agree. I mean, it's an upper lobe lesion in someone with emphysema, but I think tincture of time can be very helpful and avoid thousands of dollars of unnecessary imaging, when just a CT in 3 months would put it to rest.
Yeah, and I totally agree. I mean, you're exactly right. Our pretest probability is still very high for lung cancer here. Even using the nodule calculators, I would say it's at least 75 or 80% chance that this is going to be a cancer. But the PET isn't going to change your pretest probability, because either of them are going to be hot. So, if something like this is cold, then I wouldn't know what to do with it being this spiculated. Obviously, that last case with something solid, that would be the one utility of a PET, is if for some reason it did come back as not hot, then you could maybe argue that it's something benign. But yeah, I agree. I don't think that PET is very helpful in these acute settings, and that's why that's one of my frustrations with the lung rads, is that's one of the one of the recommendations. I think that you should have some sort of time frame, knowing that this, if you had a radiograph from a year ago and you could see something that may have been there that's getting bigger, then that changes the pretest probability. But yeah, I find these to be frustrating types of cases. I don't know. Does anybody disagree?
No, I think point well taken. Sometimes it's best just to get a short-term follow-up. Yep, exactly.
And this one, and David, this one is credit to you. This is something I learned from you recently in an email. It's a nice case. I'll just show quickly. And I don't remember the story, but it's a good case of organizing pneumonia. And you can see that he's got peripheral, reverse halos or atolls, and a little bit of ground glass too. I'm not sure the story on that as well. But the reason I show this is because one of the cases I had sent out had these really cruddy-looking, noisy, somewhat noisy reconstruction kernels. And as I had never really used GE scanners, CT scanners that much. We had some at Emory, but none at WashU. That this is using the lung kernel on the GE scanners, and David, you can supplement me too, or Jeff, that more old-fashioned kernels designed for thicker slices. When I had them redo it with a bone kernel, as you can see, actually, let me see which one it is. Yeah, I think it's this one versus this one. This is the bone kernel, but you still maintain that sharpness, but it doesn't have the really noisy edges, which I find, especially in our patients with interstitial lung disease, that sometimes it's hard to tell if they have honeycombing or traction when it's too noisy. So I've become a fan of these bone kernels like this.
This is in the user manual for as one of the old GE scanners, the 16 slice. There was a footnote that specifically said something to the effect of "Don't use lung for thinner than 5 millimeters," because it's way too sharp and it creates calcification and all sorts of badness.
And pneumothorax too. So you get black bands and white bands.
Yeah, so I think that no, this says body filter. I know there's
That's
one of these had
It's
this.
bone. It says convolution kernel bone.
It is.
Oh,
This
okay,
one,
yeah.
the last
Yeah.
one said bone.
Okay, good. Yeah.
You can tell just by putting up in soft tissue windows side by side because it's striking how different they look.
Yeah, let's see. I'll put up the soft tissue windows. I think
You just
yeah, there's the soft tissue. Yeah, you can see the difference.
say if you change the window settings so that they're soft tissues, you can tell lung from bone or bone plus.
Yeah. Yeah. What's the difference between bone and bone plus?
It's very
Is there much difference?
We use bone plus. I like it better. It's a little. I just find there's a subtle difference. I don't remember specifically. I find bone plus has just a little bit more edge enhancement that I like, but not too much. It's
Yeah. Okay.
very similar to like B7. B60 on Siemens.
Sure.
Because I see outside scans sometimes come with B70, which I think is way too sharp.
Yeah, I've seen those. I really hate those. When you get above 60 with the Siemens, yeah, depending on the machine.
Yeah, and if Brent is still on here, I know that on the GE scanners at Emory, we were just doing mostly lung window or soft tissue kernels, and not even doing a lot of bone or lung kernels. I mean, if you have a thin slice, it's still okay, but it doesn't really bring it out as much.
I've really never liked the lung kernels.
But I think it's because it's the lung. Yeah, this is what David is showing me. If you might want to try these bone or bone plus, and just see. I do like these now that I've gotten used to them. So, all right. Well, that's it for me, Jeff.
All right. Well, thanks everybody. Have a great rest of your week, and we'll continue next week.
Thanks, everyone.
Okay.
Thanks, guys.
Bye.